the main issue is that you have to prove kind of that by using those biomarkers, you improve outcome at the end. And so what we have so far is that we know we can select patients based on these markers to have a high yield on identifying atrial fibrillation on follow-up. So you can kind of target those patients who would benefit most from prolonged monitoring. So you can allocate kind of your monitoring algorithms based on these markers, and also identify those who might benefit, who do not benefit, so where you don't have to look further and to identify atrial fibrillation. So I think for the use for risk stratification, there is already quite an amount of data here we can use. I think the biomarker cutoffs, this is still a little bit of an issue because you need validation studies with the cutoffs specifically for these questions. And for MRproANP, for example, there has been a study done, a validation study to actually really validate a cutoff. So I think we are here quite already in clinical implementation. Concerning treatment, to guide really treatment and oral anticoagulation, that's a little bit of a different matter, and therefore we need obviously randomized controlled trials using these biomarkers and specific cutoffs to select patients and randomize them into either standard therapy with antiplatelets within this group where there is no atrial fibrillation detected yet, versus oral anticoagulation, and then you have to see if you reduce re-events by doing so. And currently 2 trials are enrolling patients with exactly that question. So there is the ARCADIA trial in the US, which uses NT-proBNP and other imaging markers such as echocardiography markers of enlarged atrium and ECG markers. And then there is MOSES trial. The MOSES trial is probably a little bit more pragmatic in the sense it uses only the biomarker. It uses MRproANP with a specific cutoff to select patients for randomization. And yeah, we are waiting the results of these ongoing trials. And if the hypothesis is true that that these patients could benefit from oral anticoagulation, we have another tool, and we can treat a larger proportion of stroke patients specifically based on their underlying etiology. And I think that would have a great impact if proven. So I think to make the distinction, so as I said, in the ARCADIA trial, they are looking specifically at ESOC patients, and in the MOSES trial, we are not distinguishing that. And I think the difference is there because the hypothesis is that even if you have a small vessel stroke at the beginning, it doesn't prevent you, if you have an underlying cardiac disease, of having a future stroke based on your cardiac disease. So in the MOSES trial, there is no selection based on ESOC, but every patient who has an elevated MRproANP level is potentially eligible. Whereas in the ARCADIA trial, they have a pre-selection of ESOC patients.